Welcome back to the Deep Dive. Today, we're tackling a really interesting one, adjustment disorders, or ADs. They're incredibly common in clinical
Oh,
settings.
absolutely. They pop up everywhere.
But here's the thing, they're also some of the most criticized diagnoses in the scientific world.
Hmm.
It's a strange spot to be in.
It really is a paradox. So what we're doing today is diving into one specific chapter from Kaplan and Sadock's comprehensive textbook of psychiatry, trying to distill, the essence of AD.
Right.
Our goal is really to understand why it's so popular, so widely used, even when people call it, well, a wastebasket diagnosis.
Yeah, that wastebasket label comes up a lot. And the stats back up the paradox, don't they?
Yeah.
I mean, ADs were ranked super high globally, like 7th for psychiatrists, 9th for psychologists,
Very frequent.
but then ranked lowest for ease of use or goodness of fit. So everyone's using it, but maybe nobody feels entirely comfortable with how it fits. Okay, let's get into that.
Skip.
What makes it so appealing right off the bat?
I think the core appeal, honestly, both for clinicians and for patients, is that central feature.
Hmm.
The link between symptoms showing up and some kind of external stressful event.
Okay.
It's right there in the DSM-5 classification, trauma and stressor-related disorders. It firmly frames it as a reaction to stress.
And you can see why that resonates, right?
Yeah.
If someone tells you you have an adjustment disorder, it points the finger at the stressor, the outside event, not necessarily something permanently wrong inside.
Exactly. It feels less intrinsic, less stigmatizing than maybe hearing major depressive disorder. It fits better with how people often think about stress affecting health.
Makes sense. But that's also where the scientific trouble starts, isn't it?
That's precisely the Achilles heel. See, with PTSD, the criteria for the trauma are pretty tightly defined. For AD, the DSM-5, well, it gives almost no specific rules for the stressor.
Really? Not at all.
Practically none. It could be money problems, a relationship ending, starting university, getting a tough medical diagnosis.
Yeah.
The range is huge.
Wow. Okay, so if the trigger can be almost anything, how do you actually pin down that the stressor caused the symptoms? Isn't that kind of subjective?
It is incredibly difficult in practice. You're basically inferring causality, and the DSM only says symptoms have to be in excess of what you'd expect, which leads to this fundamental, almost philosophical question the textbook raises.
Which is?
Where does a normal human reaction to a tough time stop, and where does actual clinical pathology begin? That line is blurry.
And if a clinician can't clearly put someone in another box, like major depression or an anxiety disorder, because they don't quite meet all the criteria.
Then AD often becomes the default.
Yes. Okay, so that's the wastebasket critique.
Oh,
It
yeah.
catches the cases that are sort of sub-threshold, maybe just difficult life problems getting medicalized.
That's a big part of the critique historically. But, the idea isn't new. It's been in the DSM since the very
Oh,
beginning.
really? Since DSM-I?
Yep. It came out of work during World War II dealing with severe stress reactions. Back then, DSM-I in 1952 called it transient situational personality disorder.
Transient situational personality disorder.
Right.
Quite a mouthful.
It was. Then DSM-3 formally introduced adjustment disorder and started subtyping it based on the main feeling, like depressed mood or anxiety.
Okay.
But the really significant shift, the one that changes how we frame it, came in DSM-5, putting ADs into that new chapter, trauma and stressor-related disorders.
Right. Alongside PTSD and acute stress disorder.
Exactly. That move was deliberate. It was meant to say, look, this is part of a spectrum of responses to stress. It tried to give it a bit more scientific weight.
Okay. That context helps frame it better. So let's say a clinician is considering this diagnosis today using DSM-5. What are the absolute must-have criteria, the rules?
There are 4 main ones you got to check off. First, the timing of onset. Symptoms have to start within 3 months of the stressor hitting.
3 months.
Second, the timing of remission. The symptoms need to clear up within 6 months after the stressor or its direct consequences are gone. So it's time limited.
Right. It shouldn't linger indefinitely if the stress is removed.
Precisely. Third, the severity. The reaction has to be clearly out of proportion to the stressor, or it has to cause significant problems in life, like messing up work, school, or relationships. Real impairment.
So more than just feeling down for a bit.
Definitely more. And fourth, this is crucial, the symptoms cannot meet the full criteria for another primary mental disorder. Like, it can't just be major depression presenting. And usually, straightforward bereavement is excluded unless the reaction is way beyond what's culturally expected.
Got it. So check those boxes, then you look at the specific symptoms that leads to the subtypes, right?
Yeah.
like in Table 25.1.
That's the next step. The DSM-5-TR lists 6 subtypes based on the main symptom cluster. You've got 1 with depressed mood, 2 with anxiety,
Okay.
3 with mixed anxiety and depressed mood, 4 with disturbance of conduct that's more like acting out behaviors,
Okay.
with mixed disturbance of emotions and conduct, and finally 6 unspecified for things that don't fit neatly.
6 subtypes. But you mentioned earlier, is there some debate about whether these are truly distinct?
There is. More recent research, as the chapter notes, finds these subtypes tend to overlap a lot. High intercorrelation, suggesting they might not be totally separate conditions after all. It's an ongoing question.
Interesting. So the DSM approach gives us these criteria, these subtypes, but it still feels a bit broad, maybe. How does the international system, the ICD-11, handle AD? Is it different?
It is quite different, actually, and arguably a bit more focused. ICD-11 made a couple of major changes. First, the onset window is tighter. Symptoms have to show up within 1 month of the stressor.
1 month versus 3 in DSM.
Okay. But the really big difference is in the symptoms themselves.
I see.
ICD-11 is much more specific. It requires 2 core features: preoccupation with the stressor, like excessive worry, ruminating, constant intrusive thoughts about it.
Okay, so a real mental fixation.
Yes.
Yeah.
And number 2, a clear failure to adapt, which means significant impairment in functioning. So it's not just about feeling bad, it's about being mentally stuck on the stressor and being unable to cope effectively in daily life.
That sounds much more specific than the DSM's approach. It's painting a clearer picture of the actual disorder part beyond just the emotional reaction.
I think many would agree. It shifts the focus away from just a time-limited emotional response towards a syndrome defined by those intrusive thoughts and the functional breakdown.
Okay, that comparison is really helpful. Now, let's shift gears slightly. Why does this happen? If 2 people go through, say, the same job loss, why might one develop AD and the other bounce back relatively quickly? What are the theories about why some people are more vulnerable?
That's the million-dollar question, isn't it? And the answer isn't simple. We really need to look at it from multiple angles. Psychologically, AD is often seen as a breakdown in the adaptation process.
Adaptation.
Yeah, adapting to a big life change, a transition, a loss. The idea is that the person struggles to integrate that stressful event into how they see the world, into their life story, their cognitive schema. It just doesn't fit.
Right, disrupts their narrative. And what about from a psychodynamic perspective?
Psychodynamic theories often look at relationships, specifically attunement. When someone experiences a stressor, they often signal distress, show feelings that signal danger or need. If the people around them, family, friends, don't respond appropriately, if they ignore it, criticize it, or just aren't attuned, the person is left to cope alone. That lack of relational support, that failure of attunement, is thought to contribute to symptoms developing.
So the social context matters hugely.
Absolutely. And then, of course, there's the biology.
Yes, the biological vulnerability. What's the thinking there?
A key concept mentioned is allostatic load. Think of it like the cumulative biological wear and tear on your body from chronic stress.
Okay.
It affects those critical stress response systems, the HPA axis being the main one, that hypothalamic pituitary adrenal pathway controlling cortisol, but also neurotransmitters like CRH and dopamine. If someone already has a high allostatic load from past stress, their system is kind of primed for trouble.
So even a moderate new stressor could tip them over the edge into pathology.
Exactly. Their system is less resilient, less able to buffer the new stress effectively.
Does this show up anywhere physically? Like in brain scans?
There's some emerging evidence. The chapter mentions one neuroimaging study that found patients with AD had less gray matter volume in a specific brain area, the right medial frontal gyrus.
And what does that area do?
It's involved in really important things like extinguishing learned fear, basically, learning that something isn't scary anymore, and overall emotional regulation. So having less volume there might suggest a biological reason why someone struggles to cope adaptively with stress.
Fascinating. Okay, let's talk numbers. Prevalence. You said it's super common clinically, even if general population rates are low, maybe 1–2%. Where do we see it most often?
Yeah, in the general community, it's not that common. But walk into a psychiatric clinic, boom. It's often the second most common diagnosis given at intake, around 10% of cases.
Wow, second most common.
And in hospitals, even higher, especially in consultation-liaison, or CL psychiatry. That's when psychiatrists see patients on general medical floors. Historically, AD accounts for something like 12% to even 30% of those consults.
30%, that's huge.
It is. And think about patients who are medically ill in general. One big review found AD in almost 20% of them, which, interestingly, was higher than the rate of major depressive disorder found in that same group.
Higher than MDD in medically ill patients.
Yeah.
That really underscores how vital this diagnosis is for capturing distress linked to physical health problems, doesn't it?
It absolutely does. It acknowledges the psychological impact of illness or injury. And we see spikes related to wider events, too. Think early COVID-19 pandemic, one Polish survey found nearly half of respondents had AD symptoms linked to the lockdown.
49%. Incredible.
And now we're seeing discussion around climate change, stressors, droughts, floods as potential triggers for AD, sometimes even chronic AD if the stressor persists.
Okay, so it's widespread, especially in certain settings. But despite sometimes being seen as minor or transient, the chapter makes a strong point about its potential seriousness. This isn't always a mild condition.
Not at all. That's a critical takeaway. We see a lot of comorbidity, meaning other conditions happening alongside it, like somatization or unusual illness behaviors. But the most alarming finding, repeated across multiple studies, is the significant link between AD and suicidal thoughts and behaviors.
Right, that really challenges the whole mild reaction idea.
Completely. It's not benign.
And the nature of the suicide risk might even be different than in, say, major depression.
That seems to be the case. In ER studies, self-harm attempts in people with AD often look more impulsive, and frequently there's substance abuse involved at the same time.
Impulsive acts, substance use. That sounds like a dangerous combination.
It can be incredibly dangerous. The course can be really rapid and sometimes lethal, especially in adolescents or young adults. The textbook includes this really sobering verbal case example.
Oh, yes. Can you describe that briefly?
It's about a 17-year-old boy, a high school senior. He went through a tough breakup, plus the isolation of the COVID-19 pandemic, and tragically, he committed suicide. It illustrates that classic, devastating pattern. AD triggered by stressors, likely complicated by substance use or maybe some underlying personality vulnerabilities, leading to a very rapid fatal outcome.
That really drives home the seriousness. Okay, so given how common it is and how serious it can be, you'd think we'd have really solid, well-tested treatments, right? Decades of research.
You would absolutely think that. But here's another part of the paradox. The evidence base for treating AD is surprisingly weak.
Seriously. Weak.
Shockingly so, according to the source. The first proper systematic review looking at AD treatment strategies didn't even come out until 2018. And even then, most of the studies included were rated as having low-quality evidence, often due to methodological issues.
2018. For such a common diagnosis, that's kind of mind-blowing. So if the gold standard data isn't really there, what are clinicians actually doing? What's the go-to approach?
Well, the mainstay, the thing everyone agrees is essential, is psychotherapy.
Okay, talk therapy.
Exactly. The main goals are pretty straightforward. Help relieve the immediate symptoms, get the person functioning again adaptively, maybe even better than before, and build up their coping skills for stress.
Makes sense. What kind of therapy works best?
Short-term supportive therapy is very common, but other approaches show promise too. Things like cognitive behavioral therapy, problem-solving therapies. One study found those actually help people get back to work faster.
Oh, that's a tangible outcome.
It is, and meditation training is mentioned. Plus, we're starting to see more online or digital self-help options emerge, like one called BAD.
BAD. What's that?
It stands for Behavioral Activation for Depression over the Internet. It's basically an online program designed to be an accessible self-help tool for these kinds of symptoms.
Interesting. So therapy first and foremost. What about medication? Does pharmacotherapy have a role?
It's seen as more of a complementary role, not usually the first line, but used carefully judiciously is the word often used to target specific severe symptoms.
Like what?
Things like really bad insomnia or intense anxiety that's stopping someone from engaging in therapy, maybe low-dose antidepressants or anxiolytics.
Any specific drugs mentioned?
Trazodone comes up in one small study as potentially helpful for remission, probably because it can target both anxiety and sleep issues without being a benzodiazepine. And there was mention of etifoxine.
Etifoxine, haven't heard of that one.
It's a non-benzodiazepine anxiolytic available in Europe. One study suggested it worked about as well as lorazepam, which is a benzo for the anxiety subtype of AD, but with fewer side effects, better tolerability.
Okay. But you mentioned benzodiazepines. Given the suicide risk we talked about, especially the impulsive acts, are benzos generally advised against?
Extreme caution is definitely needed. Given the impulsivity risk, the potential for substance abuse comorbidity, the addictive potential of benzodiazepines makes them risky in this population. They're generally not a first choice, and if used, it should be short-term and carefully monitored. Psychosocial support, the therapy, really needs to be the foundation.
Right. Therapy first, meds as targeted support. Be careful with benzos.
Mm-hmm.
Got it. Okay, this has been a really thorough walkthrough. If we pull back for a second, how would you summarize the place AD holds in psychiatry today?
I think the chapter paints it as occupying this necessary but scientifically kind of awkward space. It clearly serves a clinical need. It acts as this transitional diagnosis, maybe less stigmatizing, allowing doctors to intervene when someone is clearly distressed by life events.
So the science is still catching up.
Pretty much. The move to classify under trauma and stressor-related disorders in DSM-5 was a big step, trying to push it towards more rigorous study. The hope is we'll develop better models that look at both the stress and the person's resilience factors to predict who's really at risk.
And thinking about the actual use of the label, that story at the end of the chapter about Dr. S was quite telling.
Oh, absolutely. The pediatric resident dealing with her own injury and her child's new bipolar diagnosis, a huge amount of stress.
And she specifically asked for the adjustment disorder diagnosis rather than major depression.
Exactly. And her reason perfectly highlights the diagnosis's practical utility beyond just the strict science. For her, AD was a way to communicate to important third parties, the medical board, her employer, insurance, that her severe struggles were an understandable reaction to overwhelming external circumstances.
Not a sign of a permanent internal problem.
Precisely. It framed her dysfunction as time-limited, situational. In that sense, the diagnosis, even with its scientific vagueness, acted as a protective shield for her career and reputation. It shows how clinical judgment sometimes relies on the label's function, its meaning in the real world, as much as its precise scientific definition.
That's such a powerful point to end on. That sometimes the vagueness is actually part of its utility, offering flexibility and protection. Well, this has been incredibly insightful. We really hope this deep dive has helped you, our listener, navigate the complexities of adjustment disorder.
It's definitely a diagnosis that makes you think about that fine line between a normal response to hardship and clinical pathology.
Absolutely. Thank you for joining us on the deep dive.